Hello. Uh, okay, so good evening, everyone. So we just wait for a confirmation from few people and then we'll start. Okay, so we are waiting for the confirmation. For the audio and video is so good evening, uh, everyone. Just check if my audio is fine. If there is any issue, just text here in the comment section. And we'll proceed forward. So, good evening, everyone. M- Myself, Dr. Rijul Agarwal. I'm the Orthognatic faculty at DAMS. So, like last time, also, we did the topic on cleft. I've started my lectures, these YouTube sessions from topics because these are the least touched, and the current NEET and INI both exams are carrying minimum 3 to 4 questions out of this topic. So if we take out 14 questions in NEET exam and 3 to 4 questions are coming out of these topics, so that they carry a huge weightage. So that's why I have started from these, and generally during our lectures we cover them at the last. So most of them, the students tend to miss them out or think that it's beyond, let's focus on growth, appliances, and tend to ignore these topics. But just to highlight, these topics aren't to be ignored at all. So okay, so once again, good evening, everyone. We are taking up two topics, that is the orthognatic surgery and obstructive sleep apnea. Two different topics but carrying huge relevance from exam point of view nowadays. Okay, so starting with the first one, that is the orthognatic surgery. The first slide itself carries 2 3 questions which have come in the last exam only, both NEET and IN exam. So first, what is Epker's classification of discrepancy? So what happened was, the orthodontist during their discussions, they defined the limits of movement which can be carried out by orthodontic tooth movement through growth modification or through surgical correction. So this was the classification of discrepancy, or the discrepancy table. So what is it? So there are 4 circles, that is the innermost circle, the middle circle, the outer, and the outermost. This outermost circle concept is the latest one. Okay. So what are these circles? So the inner circle. Inner circle represents the movement which can be carried out by orthodontics alone, that is through braces and wires. That is the movement which can be carried out through braces and wires, both in anteroposterior, vertical, and transverse direction as well. Okay, so in all 3 planes, the innermost circle represents the movements which can be carried out only through braces and wire. Moving ahead, the middle circle. So this is the middle circle. So what does the middle circle represent? The middle circle represents the movements which can be carried out through growth modification. So what are these growth modifications? So the growth modifications are the ones which can be carried out through our functional appliances. Now what functional appliances includes: the twin blocks, bionators, Frankel, headgears, face masks. All of these encompasses the movements which in the growth modification thing. Next, these are the innermost, the middlemost. Next is the outer circle. or this one. So the outer circle represents the thing movements which can be carried out with orthognatic surgery. Now there was a confusion which occurred in the NEET exam. The option contained orthognatic surgery and orthognatic surgery along with orthodontics. So students, please note, no orthognatic surgery can be carried out without any kind of orthodontic. We require orthodontics, then only the surgery can be done. So the correct answer in the NEET exam was orthodontics along with orthognatic surgery. So the outer circle represents the movements or the corrections which can be done via surgical. That is both combined with orthodontics plus orthognatic surgery. Okay. So this is the outer circle. Now the latest concept or the newest comes the outermost circle or the circle which is beyond these three, that is this. It is not represented in the diagram, I have drawn it myself. So this outermost circle represents the movements which can be carried out via distraction osteogenesis. I'll repeat again, the outermost circle represents the movements which can be carried out via distraction osteogenesis. Okay, so अगर एग्जाम में outermost word यूज़ किया है तो प्लीज़ रिमेंबर ये the examiner has asked according to the latest protocol. So that means the outermost is the distraction, या option में distraction mentioned है. So the outermost circle represents the distraction osteogenesis. Okay. Moving ahead, another concept, that is the term by the skeletal anchorage. So the skeletal anchorage includes mini plates, tats. So this circle would be beyond the middermost and before the surgical correction. So it comes in between these two. This is again a newer thing, that is the movements which can be carried out by skeletal anchorage, that is the use of mini plates and tats. So there is a chance they can ask you in the next exam. So the skeletal anchorage comes between the middle and the outer circle. Okay, so I hope this is clear. So this is the first, the classification or the envelope of discrepancy. This was given by एपकर. सो द एपकर्स क्लासिफिकेशन ऑफ डिस्क्रिपेंसी एग्जाम में जनरली वो एनवेलप ऑफ डिस्क्रिपेंसी करके दे आस्क यू. ओके, दिस फिगर्स रिप्रेजेंट्स both in the maxillary and the mandibular arch, the sagittal, the vertical and the transverse movement which can be carried out. This table represents the movements in mm. I hope this is not important from exam point of view, so just to complete the topic I mentioned it here. No one is going to ask you what the movement in mm is. Okay, so the orthodontics, again just remember orthopedics. Orthopedics again means the movements which can be carried out by growth modification. Functional jaw correction, functional jaw orthopedics, growth modification, these are the common synonyms which can be used to represent the middle circle. Okay, so next comes the prediction tracing. So what is prediction tracing? So before orthognatic surgery is done, there is a series of steps or series of steps which are done before a surgery is done. So what are these steps? What is the need? So these steps are done to plan out the surgery first. We cannot directly initiate the surgery before, we cannot bring the patient directly to the OT table before planning it out. So these plannings are done prior to the surgery. So first step is the prediction tracing. What is prediction tracing? नाम में ही लिखा है predict. So we trying to predict or get the idea what kind of movement we need to be done on the OT table. So that movements are first done on a lateral cephalogram, and that movements are done with the help of pen and paper. So what is done? A post-operative profile of the patient is predicted by cephalometry. So what is done? A pre-treatment cephalogram is traced, and on that tracing we trace the post-operative profile or what the prediction or what the desired profile is needed. desired profile is traced on the lateral cephalogram. How it's done? The osteomatized segment is cut out and moved as calculated. So how this calculation is done? This calculation is done using cephalometric analysis. And what was the cephalometric analysis? If you all remember from your lateral ceph analysis, that is the COGS analysis. So based on the COGS value, does COGS stand for? Cephalometry for orthognatic surgery. So from COGS value, these segments are moved accordingly and they are traced. So what these tissues changes are marked on the tracing to give the post-operative profile of the patient. Okay, I hope it's clear. So this is the prediction tracing, which is done on the lateral cephalogram. So from your exam point of view, two things are important here. So what is prediction tracing? First thing, it is done on lateral cephalogram. Okay, and how it's done? It takes the help of the COGS analysis, that is the cephalometry for orthognatic surgery. These two things are important. You should remember from your exam point of view. Okay. Next is model surgery. So what is model surgery? जो चीज़ हमने अभी लैटरल सेफलोग्राम में की वही सेम चीज़ हम एक डेंटल स्टोन कास्ट पे करेंगे. Okay, the amount of movements in mm and the cuts are done on the models, and based on it, the new desired occlusion the models are set. So what is the need to do this model surgery now? हमने lateral cephalogram पे वो सर्जरी करके हमने ऑलरेडी देख ली कि प्रोफाइल क्या होगी. So model surgery is done to construct splints. So what are splints? I'll try to explain it here. What happens जब हम OT में हैं, we have cut the maxilla and mandible, हम new desired position पे jaw को लाके रख देते हैं. So at that new desired position, the jaw should be stable because both the segments sometimes are osteomatized. Means both the segments are cut from their respective bones. They're free to move. So when we fix them at the new position, there should be a desired new position पे जब हम उसको ला के रख देते हैं, it should be stable. So for that, splints are constructed which acts as a marker. Okay, just imagine two jaws hanging on, like loosely hanging, they should be stable. Okay, so these splints are constructed on model. So from exam point of view, model surgery is done for the construction of splints. So ये हो गया हमारा planning phase. I hope it's clear until now. So beginning with the steps involved in the orthognatic surgery procedure, that is the first, the pre-orthodontic preparatory phase, pre-surgical orthodontic treatment phase, surgical phase, post-surgical phase, prosthodontic treatment phase or the rehabilitation of occlusion and aesthetic, and follow-up and retention. So अभी हम starting with the surgery requirements. So commonly तीन चीज़ों के लिए surgery चाहिए होती है. For anterior posterior correction, that is for class 1, 2 और 3 correction. Vertical correction, that इसमें जो दो broad phases आते हैं, that is the open bite and deep bite, and transverse correction to correct the cross bites. Okay, so what is the pre-surgical orthodontics? Pre-surgical orthodontics is done to prior to the surgery. It is done to not to make the occlusion relationship as ideal as possible. So what is the need? Its need is to carry out decompensation of occlusion. Pre-surgical orthodontics is done to carry out decompensation of the occlusion. So what is decompensation and compensation? जो आपके एग्जाम पॉइंट से इम्पोर्टेंट है. So students, please note what happens Supposedly we take the exam, start with the class 2 case, skeletal class 2. So as we all know, in skeletal class 2 there is an increased overjet, the maxilla is ahead, the mandible is behind. So what does nature do is, to compensate this overjet, the nature tends to procline the lower incisors and retrocline the upper incisors, so that the upper and lower teeth trying to meet and reduce this overjet. Why it's done? अगर हम प्रोस्टो क्लास से जाने, if you remember, the anterior guidance. So as to achieve anterior guidance, nature tends to compensate these teeth. That is, retrocline the upper incisors and procline the lower incisors. So अगर इस compensation teeth position पे we tend to advance the lower jaw or bring the upper jaw back in class 2 correction, what will happen? We will tend to do, the surgery will be incorrect. So first we have to remove these compensations. So what it is written is that if the surgeries were to proceed with this proclined lower incisor, the permissible movement would be required, restricted by the amount of overjet. Okay. So the profile changes would not be as desired achievable, which would have been achievable had these compensations been removed. यही चीज़ हम इधर diagrammatically represented है. What happens here is, there are the incisors are proclined. So first we tend to increase this, remove this compensation. So अगर proclined lower incisors है, what we need to do is retrocline these incisors. और retrocline करने के लिए हमें क्या चाहिए होगा? Space. And for that, space is created by extraction of lower premolars, lower first premolar extraction. So often in skeletal class 2 cases, lower first premolars are removed to retract and upright the lower anterior teeth and allow for greater skeletal movement. I hope it's clear. This is exactly opposite to the compensation extraction pattern which we have discussed in a class. Okay, so extraction pattern in decompensation is lower first premolars, so as to reduce the proclination of the lower anteriors. Okay, so what happens is, when we retract the lower incisors, there is an increase in the overjet, and then we are able to carry out the surgery very easily and bring the mandible forward. Okay, so if you remember, in the first slide only I mentioned that no orthognatic surgery can be carried out without prior orthodontics. Okay, so pre-surgical orthodontic phase is necessary. Okay, अगर हम skeletal class 3 में जाए, तो what happens is, what a kind of compensation would be present would be, the upper incisors would be proclined and lower will be retroclined, again to achieve anterior guidance. So what we do is, the upper premolars are extracted in skeletal class 3, upper premolars are extracted so as to increase the negative overjet, and then the surgery required will be either maxillary advancement or mandibular setback, or both would be carried out. Okay, so the pre-surgical orthodontics involve placing the teeth to their normal inclusion, resulting in increase in a reverse overjet in skeletal class 3. Okay, I hope it's clear until now. So this is the pre-surgical orthodontics. So now we are reaching the point of surgery. So what are the appliance system? So before the patient is taken to the OT table, there should be a heavy rectangular wire should be present. The dimension should be 19-25-inch SS. Wire should be present. We cannot use an beg appliance, or nor can we use ceramic brackets. Ceramic brackets can only be used if the patient demands only on the anterior teeth. So 1925 SS, metal brackets, and that too MBT metal bracket should be present from full upper lower 7 to 7 with 6-7 banded. Okay, so this is the pre-appliance system needed before the patient is taken for orthognatic surgery. Next comes the second important question, or second question which is most commonly asked. in your exam, the hierarchy of stability. The most stable procedure, the least stable procedure. So the most stable, this diagram represent the exact order of the stability. Okay, so the most stable would be the maxilla up or mandible forward, and the least stable would be the maxilla widen or the increase in the transverse dimension. Okay, so just remember the most stable maxilla up, next would be the mandibular forward or mandibular advancement or chin in any direction, and the least stable would be the increase in the transverse dimension or widening the maxilla. Okay, so this is the next most common question after the envelope of discrepancy, which is commonly asked in the exam. Now coming to the surgical orthodontics, I'm not going to discuss the cuts which are given and where it is given. I'm only going to discuss the orthodontic part. Test, it's taken up with the oral surgery faculty. So the common surgical procedures are the BSSO, bilateral sagittal split osteotomy, the Leaford 1 osteotomy for maxillary movement impaction, genioplasty for chin correction, and frenectomy for after diastema closure. Okay. So this table summarizes all the surgeries which are done for the maxillary or mandible problem. Okay, just remember their names if they ask. Okay. So for anteroposterior correction, that is the, in case of maxilla, advancement is done via Leaford down fracture and advancement. Okay, the limits of this advancement is limited by the length of the vascular pedicel and the pedicle and the soft tissue compliance, which limits its forward movement, and retraction is difficult because of the presence of the pterygomandibular plates. That's why the retraction of maxilla is difficult because of the presence of these plates and tuberosity. Okay, so what is done is, in most commonly for maxillary retraction, anterior segmental osteotomy or wondrous procedure is done. What we do is, instead of taking the whole maxilla back, we extract upper first premolar, and the space which we get, we cut that much segment and bring that much amount of maxilla back, instead of taking the whole maxilla back, because of the presence of these two things, pterygomandibular plates and tuberosity. Okay, that's why anterior segmental osteotomy, that is only the anterior segment is retracted, and that procedure is known as wondrous procedure or wondrous procedure, which is carried out by extraction of the upper first femur. Okay, this is the surgical part. So similarly for anteroposterior correction in mandible, advancement is done by BSSO, that is bilateral sagittal split osteotomy, and is the most preferred technique. Why? Because it can be done carried out intraorally. Okay, and the most common drawback or complication is the damage to the inferior alveolar nerve, altered sensation post-operative. Okay, so this was the short summary of the anteroposterior correction. Similarly for vertical correction, so for vertical correction, maxillary both superior and inferior position movements can be carried out. Superior position, as I have already told you, is the most stable correction, carried out by the same Leaford 1 down fracture technique, and inferior movement is the least stable, so it's stabilized by the presence of, by insertion of bone grafts or hydroxyapatite blocks between the segments to increase the stability. Or for mandible, so if you want to shorten the length of mandible in cases of class 3, done by inferior border osteotomy, and for similarly for advancement of mandible, BSSO. But as I've already told you, but the अगर हम mandible bone की length increase कर सकते हैं, we cannot increase the nerve length, so it leads to, most commonly leads to relapse to the pre-surgical position. That's why this concept of distraction osteogenesis came up. In mandibular advancement, if you need to advance the mandible, most commonly beyond some length, this distraction osteogenesis is the most commonly preferred procedure in these cases. Okay, so for correction of transverse relationship, maxillary constriction or expansion can be accomplished by segmenting the maxilla. As we all know, the mid-palatal suture fuses once the growth is completed after 13 years of age. So after that, no expansion appliance will work. Okay, so we need to cut that suture first, and then we can bring about the expansion using any appliance. And in this INA exam also only, they they gave you an image-based question on this kind of appliance only. So what is done is, in the OT table we've cut the mid-palatal suture, and then we, using implants or any, we drill the appliance in that patient's mouth, and after simple jack, like the turning of the screw of the jack screw, the segments are expanded. So this comes under SARME or SARPE. What is SARME? Surgically assisted rapid maxillary expansion. Surgically assisted, why? Because we have cut using the bone cuts, we have removed that resistance of the mid-palatal suture, and afterwards simple maxillary expansion screw is placed to carry out the expansion. Okay, but please note, not only cutting the mid-palatal suture, we need to do a Leefort 1 down fracture as well. Why? अगर हम simple mid-palatal suture को cut कर देंगे, the maxillary bone will just tip. Okay, but because it attached to the nasoalveolar segment as well from above, so we need to cut that segment as well, so as to bring about the complete expansion and prevent relapse. Okay, so Leefort 1 fracture along with the mid-palatal suture fracture, both are done by the surgeon before carrying out correction of the transverse relationship in the maxilla. Whereas mandible, as we all know, there is no kind of suture which is present, okay, which will help in carrying out, which will this expansion. So we do distraction osteogenesis. We don't have a mid-palatal suture in mandible. Mandible is a complete one bone, if you remember from embryology classes. So the expansion is not effective. Distraction osteogenesis is most commonly carried out. Okay, after the surgery is done, post-surgical orthodontics is done. What is post-surgical orthodontics? Settling of the occlusion and finishing to achieve maximum intercustation. Okay, I hope it's clear, the orthognatic surgery part. Anyone has any doubt? Okay, if anyone has any doubt from orthognatic, this was a short revision, or we can say important points from the orthognatic surgery point which we have taken up. Okay, okay, so we'll proceed. If anyone has any doubt, you can write in the comment section. Okay, so moving ahead, obstructive sleep apnea. So what is apnea, hypopnea and obstructive sleep apnea? So apnea, as we all know, apnea is the cessation of airflow. इसकी definitions पे just please ध्यान देना है. That is, that lasts at least 10 seconds with oxygen desaturation of more than 3%, with or without associated with arousal from the sleep. So तीन terms, at least 10 seconds desaturation of more than 3% associated with arousal. So it occurs when the throat muscles and tongue relax during sleep and partially block the opening of the airway. So what is hypopnea? Hypopnea is the reduction in the amplitude of airflow that occurs more than 50% of the baseline and occurs for at least 10 seconds. Okay. अगर ये 50% से ज़्यादा रिडक्शन है, that is termed as hypopnea with accompanying oxygen desaturation of at least 3% and or associated with arousal. So what is obstructive sleep apnea? अगर ये दोनों एपिसोड्स एपनिया और हाइपोपनिया के एटलीस्ट 5 एपनियाज और हाइपोपनियाज पर आवर ऑफ स्लीप ऑकर होते हैं, resulting in sleep fragmentation and decreased oxygen saturation, is termed as obstructive sleep apnea. Okay, again I'm repeating, these two episodes of apnea and hypopnea occurring more than 5 in number per hour of sleep, resulting in sleep fragmentation, that is frequent arousal from the sleep, is known as obstructive sleep apnea. So what are the predisposing factors which lead to these obstructive sleep apnea episodes? First is age. With increasing age, there is loss of muscle and replacement fat, leaving the airway narrow and soft. Next is sex predisposition, that is men or males have a greater risk of this obstructive sleep apnea. Third is the retroposition maxilla and mandible. अगर maxilla mandible की position ही backward है, leading to the shortening or reducing the volume of the airway, is a predisposing factor. Obesity, as we all know, is a pharyngeal deposition of fat around the airway, leading to the narrowing of the airway. Enlarged tonsils and adenoids in children. Drugs, that is increase in the degree of relaxation of upper airway. What are the common drugs? That is alcohol, sedatives, sleeping pills, anesthetics and narcotics, and smoking, leading to the swelling of the upper air, are the most common predisposing factor. So as we all know, this table from our physiology classes, that is the sleep stages, that is the rapid eye and non-rapid eye movement. So from our orthodontic point of view, we should know that the OSA patients tend to spend a majority of their time in stage 1 and 2 of the non-rapid eye movement sleep. Okay, so what will happen अगर if we know from a general knowledge, अगर पेशेंट की स्लीप प्रॉपर नहीं होगी, फ्रीक्वेंट अराउजल्स होंगे, इट विल अफेक्ट इट्स प्रोडक्टिविटी एंड हेल्थ, कार्डियोवैस्कुलर डिसऑर्डर्स एंड स्टफ. ओके, so what is the result? The result is that patient complains of very unrefreshing sleep. Okay, so what does it result in? Results in excessive daytime sleepiness, performance and cognitive derangement, cardiovascular dysfunction, leading to systemic hypertension, right heart failure and cardiac arrhythmias. These are the most common sequelae of this obstructive sleep apnea. Okay, so what happens? How is this normal breathing restored? अब जब breathing stop हो रही है, airway का volume कम हो रहा है, body को oxygen तो चाहिए. So what happens? How does the normal physiology is restored in this person? So during the apneic event, as I've already told you, the person is unable to breathe in oxygen and breathe out carbon dioxide. जब carbon dioxide breathe out नहीं होगी तो क्या होगा? It gets to tend to accumulate in the blood. So what happens? As we all know from physiology, अगर हम carbon dioxide level बढ़ता है, brain को direct alert भेजता है lungs to resume the breathing. So what happens? Breathing is resumed often with a loud snort or gasp, and the patient ekdam se gets aroused from his or her sleep. Okay, so these frequent arousals which are necessary for breathing to restart prevents the patient from getting enough restorative deep sleep. Okay, I hope it's clear now. So obstructive sleep apnea is basically this frequent arousal which occur due to apnea and hypopnea events. So what is the normal anatomical variation in the upper airway which occurs in these patients. So upper airway, as we all know from an anatomy, is a non-rigid structure which consists of hypopharynx, the oropharynx and the velopharynx and the nasopharynx. So what happens during inspiration? There is a reduce in the upper airway space due to below the subatmospheric pressure. Why it happens? Because the lungs expand, diaphragm moves downwards. How does the lung expand? Because of the contraction of the intercostal muscles, leading to the increase in the volume within the lung and the decrease in the pressure. So what has happened? The air comes because of the reduced pressure. As we all know, air flows from high pressure area to low pressure area. So the air gets inhaled. So the negative pressure tend to change the shape of the airway, which is resisted by the activity of the tensor palli palatini and the genioglossus muscle. So what happens in these OSA patients, as we all know, seen the predisposing factor being the obesity or increasing age, the reduction in the activity of these muscles, that is the genioglossus and the tensor palli palatini, results in the decrease in the airway space or the volume of the airway. Okay. So this is the anatomical variation which occurs in these OSA patients. So how to diagnose this? A patient जो आएगा, he most commonly comes with the, or most of the patients nowadays are not aware that this unrefreshing sleep or daytime sleepiness is because of this reason. Okay. So how to diagnose it? So the gold standard of diagnosis is polysomnography. So for your exam point of view, what is the gold standard of diagnosing sleep apnea? That is polysomnography. So what it is done is, it involves a sleep study. It is done is, the recording of sleep pattern, breathing pattern and oxygenation is done during, involving the EEG, ECG, EOG and EMG monitoring is done during the patient, when the patient sleeps, and based on the polysomnography the AHI scores are given. So the next question which is important for your exam point of view is the AHI score. So in a normal patient, the AHI score should be less than 5. Mild OSA, the AHI score is between 5 to 15. Moderate is between 16 to 30. And severe is greater than 30. So just remember these scores from your exam. Okay. So first method of diagnosing obstructive sleep apnea, or the gold standard, is polysomnography. Next is the oximetry, which we all remember. Approximately 2 years back, every household had this pulse oximeter in their household, which measures the oxygen desaturation or the oxygen level in the blood capillaries. If it's reduced, okay, this is a at-home diagnostic tool which is now available, I think, in most of our household. Next is the lateral cephalogram. So how does lateral cephalogram help? As I've already told you in the slide on the predisposing factor, retroposition maxilla or mandible leads to the blockage of the airway, and that's why it can lead to the obstructive sleep apnea. So lateral cephalogram can also be used to diagnose this obstructive sleep apnea in such patients. Sometimes it is also used to demonstrate adenotansular hypertrophy and other airway lesions. Okay, so for exam point of view, which analysis is used for airway analysis for lateral cephalogram is the McNamara analysis. Just remember this term. McNamara analysis is used to measure the airway volume on a lateral cephalogram. Okay, so on a lateral cephalogram, what will be the common clinical and radiographic findings which you will see is mandible retrognathia, protruded maxilla, retroposition tongue and high mandible plane angulation. That is the vertical growth pattern. Okay, I hope it's clear until now. So we have done the predisposing factor, the pathophysiology, and the diagnosis of obstructive sleep apnea. Next come the treatment options. So what are the treatment options? Based on the first predisposing factor which you have seen, that is the obesity. So first treatment option would be behavioral modification, like increase in the exercise, sleep to reduce obesity, sleep position change, and weight control by modification in the lifestyle by dietary modifications, etc. Definite modality would include continuous positive air pressure. Okay, a patient breathe नहीं कर पा रहा है, there is increase in resistance of the airway. So by pressure हम air को inject, we try to inject the air in by pressure into the patient's airway tract or the lungs. Next would be अगर maxilla mandible retropositioned है, surgery can be done to bring them forward. And lastly, if none of them works, we can take the help of oral appliances to bring the mandible forward. So we'll do them in detail, each one of them. First is the continuous positive airway pressure or CPAP. What it does is, through an oxygen mask, okay, room air is under pressure, is pumped inside the patient's lung. Okay, so the most common disadvantage is the poor compliance, because the patient is unable to sleep with that huge mask on his forehead. So this is the figure of a continuous positive airway pressure used for the treatment of severe OSA. Okay, so patients are unable to be compliant because of this nasal mask, because there are fear of claustrophobia, headaches, mask leaks, eye irritation, and sinusitis. Okay, so इसका alternate क्या है? OPAP, that is the oral appliance, is a oral positive airway pressure is an alternative to this CPAP technique. Okay, next treatment modality would be surgery. As I've already told you, these are done to advance the maxilla or the mandible so as to increase the airway volume. So which includes intranasal procedure, reduction glossectomies, uvuloparyngoplasty procedures, and tracheostomy. Disadvantage again would be the pain and expense of the surgery and poor long-term success rate, because the obstruction is present at multiple levels. What it means is, as I've already told you, the upper airway anatomy, it comprises of hypopharynx, nasopharynx, and the velopharynx. So अगर obstruction mouth level पे present है, only that it can relieve. अगर obstruction उससे ऊपर या नीचे है, advancement surgeries do not help. Okay, so what are these advancement surgeries which we have already discussed? Lefort 1 osteotomy and BSSO for mandibular and maxilla and mandibular advancement respectively. Okay, please note, in this case surgeries are done for the treatment correction and not for profile correction. So if the surgery is carried out for the treatment of obstructive sleep apnea, leads to the worsening of profile, another disadvantage of carrying out surgery in OSA patients. Next, for your exam point of view, these oral appliances, इनकी figures बहुत important है. That is, first oral appliances are the tongue retaining and tongue repositioning appliances. So what it is seen is, due to a retroposition tongue or the backward position of tongue also leads to the reduction in airway volume. So what these appliances, first the tongue retaining appliance, tongue retaining device, it was given by Cartwright. So what does these appliances do? The patient brings his or her tongue forward into this. What it does is, when he brings the tongue forward, this leads to creation of a suction or a negative pressure inside the mouth. Negative pressure or suction is created, and as we all know, increase in the negative pressure or suction, the air rushes inside the airway tract. Okay, so the forward positioning of the tongue leads to the creating of negative pressure or suction inside the airway cavity, leads to the increase in the airway pressure. Next is the tongue repositioning barrier with oral shield. similar kind of appliance. So this has a funnel kind of shape of a present. Okay, so patient brings his tongue forward into this of funnel oral sheath, and similar kind of mechanism is employed. So just remember these two images for treatment of, these are the oral appliances or the tongue retaining or tongue repositioning appliances for correction of obstructive sleep apnea. Next are the mandibular advancement devices which set or recorded mandibular advancement. Okay, so instead of surgery, these appliances are given. These are similar kind of appliances which we have discussed in the growth modification, that is the twin block, the simple splint, activator, bionator, Karvitsky appliance, removable herbs appliance, and the commonly used twin block. Okay, these are the appliances which we have already discussed in the myofunctional or the growth modification appliance. But instead, here we are not giving these appliances for growth modification. Here we are just giving the appliances for so that the patient brings his or her mandible forward and in turn increase the volume of the airway. Okay, so this last is the most common appliance which is used, that is the ओएसएस appliance. इस बार INI एग्ज़ाम में a lot of appliances की images आई है, that's why I have mentioned them here. That is the OSS appliances. Okay, this is an oral appliance for oral or nasal airway system. Okay, so इसका advantage क्या है? Not only it brings the mandible on forward, it has इसमें जो ये two bulbs which you can see, these goes inside the nostrils and expands them. Okay, so they acts as nasal dilators. This is the OSS appliance. This is a newer kind of appliance which is used for the treatment of obstructive sleep apnea. Okay, so for OSA, just remember the diagnostic tools, the appliance images, okay, the pathophysiology. Okay, this is a newer point. Okay, a relatively newer topic, but catching up relevance in this time, obstructive sleep apnea. Okay, so I hope it's clear. If anyone has any doubts, you can just write in the comment section. I'll wait for 2 minutes. Okay, so if anyone has any doubt, you can tag me, you can message me, or okay, just keep on studying and all the best for your upcoming exams. Okay, so I'll just end the session here.